Clinical trials are absolutely critical, aren't they, for getting new medicines, new treatments out there. Science moves forward because of them.
Totally. They're fundamental. But, for the patients actually in the trials,
Yeah.
it can be a massive undertaking, really
No,
demanding.
you really can. It's not just here, take this pill. There's so much more involved.
Oh, definitely. The time commitment, the travel, which can be frequent, loads of tests, trying to understand complex info, and all while you're likely dealing with a serious illness.
And that brings us to our deep dive today. We're focusing specifically on trials for pulmonary fibrosis, PF, and other related conditions, interstitial lung diseases, or ILDs.
Right. And in this area, researchers face some, pretty unique and significant challenges just getting patients enrolled and then keeping them in the study.
Yeah, these are conditions that really affect breathing energy levels.
Massively. So things we might take for granted, like traveling to a clinic or even sitting for appointments, can become incredibly difficult. Participating in a trial is a huge ask.
A really huge ask. So the material we're digging into today is this really insightful study. It's by Steve Jones and his team, published in ERJ Open Research.
And the title gives you a clue. Clinical Trial Simulations in Pulmonary Fibrosis, Patient-Focused Insights and Adaptations.
Patient-focused insights, that's the key bit here, isn't it?
Exactly. What's so clever, I think, is their method. They didn't just guess why patients might struggle or drop out. They went straight to the source.
But not just with a standard questionnaire. They did something more immersive.
Yeah, they set up these virtual simulations, basically mock run-throughs of planned phase 3 trials before they launched.
So they got patients, caregivers, even healthcare professionals involved.
Mm-hmm. Had them walk through parts of the trial experience, reviewing consent forms, looking at visit schedules, thinking about procedures like home monitoring devices.
Kind of like a trial for the trial itself.
Pretty much a dress rehearsal. It gives people a tangible feel for what they'd be signing up for.
Okay, so our mission here is to unpack what they learned from that. What specific barriers did PF patients flag up in these simulations?
And crucially, how are researchers using those insights? How are they changing things to make trials, better for the people taking part?
It feels like a really important shift, putting the patient's lived experience right at the center of the design process.
It absolutely is. So, okay, the simulation itself, what did that actually involve for the participants?
Well, they got the kind of documents you'd normally receive, right? Like the informed consent form, which can be pretty dense.
Very dense. And the schedule, when do you need to be at the clinic, what happens when you're there, how long it takes.
And they also got to see or interact with potential home equipment. You mentioned home spirometry.
Yeah, exactly. The device for measuring lung function at home. They got to look at that, thought about using it.
So they get a real practical sense of the trial's demands. Then what? What was the next step after they'd gone through the simulation?
The debrief. This was critical. Afterwards, researchers held detailed interviews, discussions, really trying to capture immediate reactions, concerns, the overall feeling about the simulated trial.
And that's where the really valuable stuff came out.
Straight from the horse's mouth. Patients, caregivers, clinicians, all their perspectives.
So listening to those debriefs, what were the big things that stood out, the major hurdles?
Well, overwhelmingly, the physical burden of the disease itself. Fatigue, breathlessness. These weren't just symptoms on a list.
They were framed as direct obstacles to participation.
Exactly. Obstacles to doing the practical things the trial required, like traveling to the site, enduring the time at the site, which can often be quite long.
Yeah.
And even just having the energy for the assessments they needed to do there.
Wow. It really highlights how the illness itself directly impacts the logistics, doesn't it? It makes standard trial activities feel overwhelming.
Precisely. And it wasn't just physical stuff. People also talked about the human side. Feeling maybe a bit uninformed, not knowing quite what to expect.
A lack of support, perhaps?
Yeah, potentially a lack of support from the trial system. And also, critically, this feeling that maybe their effort, their huge time commitment, wasn't fully appreciated.
That's tough. The psychological side. If you're already ill, putting yourself out there for research, feeling undervalued or lost would add so much stress.
It absolutely would. It could easily make you think, can I really keep doing this?
Yeah.
It shows engagement isn't just about smooth logistics.
It's about trust, feeling respected.
Definitely. Feeling supported through what is, let's face it, a really demanding process.
Yeah.
Anxiety about the process itself can stop people continuing.
You mentioned the home spirometry simulation. Now that sounds like something meant to help, right? Reduce the burden by doing tests at home.
That was the idea.
How did people react to that?
Well, that was interesting. The feedback was mixed. People definitely saw the plus side, convenience, not having to travel for those specific tests. That was a big tick.
Okay, so the principle was good.
The principle, yes. The idea was popular. But, and this is a big but, people had real concerns about actually doing it.
Like, how?
Could they handle the device properly? Could they perform the breathing maneuver correctly to get an accurate result? What if there were technical glitches?
Right. So convenience is great, but not if it introduces a whole new layer of anxiety about getting it right, especially unsupervised.
Exactly that. It's a really important distinction. It's not just, here's the tech. It's, do you feel confident and supported using it accurately?
Okay. So the researchers get all this incredibly specific feedback. The fatigue issue, the need for better support and info, the nuances around home tech. What did they do with it?
This is where it gets really practical. They took these insights, discussed them with advisory boards, patient groups. Clinicians were involved there too.
Right.
And they made concrete changes, adaptations to the actual protocols for the planned phase 3 trials.
Okay, let's hear about those. How do they translate insights into action?
Well, several key things. To tackle the visit burden, they allowed for remote assessment of patient-reported outcomes. Meaning patients could fill out questionnaires about symptoms, quality of life, that kind of thing, from home, not only when they came into the clinic.
Ah, that directly addresses the time and energy drain of being on site. Fewer trips, less waiting around. Makes sense.
Total sense. They also introduced more flexibility in visit scheduling and, importantly, enhanced travel support.
Like actual help with getting there?
Yes, acknowledging how physically hard it can be for people with PF. Help with costs or arrangements, practical stuff.
That seems like a very direct response to that fatigue barrier we talked about.
It is. And for the concerns about feeling uninformed or unsupported, they planned specific information campaigns for patients and caregivers.
So, better communication, clearer ongoing.
Exactly. Making sure people feel in the loop, knowledgeable and supported throughout the whole trial journey.
And I noticed they also mentioned training for the site staff and investigators, focusing on patient needs. That feels really significant.
Oh, absolutely huge. Because it's not just about following the protocol steps, is it? It's how the research team interacts with people, understanding their lived experience.
Building that trust and appreciation people felt was maybe missing.
That's it. Fostering empathy, ensuring supportive interactions. It's vital for keeping people engaged, for retention.
So really, by taking the time up front before launching the trial to do these simulations and properly listen, they could head off a lot of potential problems.
They could identify and proactively mitigate factors that might otherwise have made patients feel the trial was just too much or led them to drop out. That's the power of this approach.
That really is the core finding then. The simulation pinpointed these crucial barriers direct from patients.
Which led directly to practical, patient-friendly changes in how the trials would be run.
And the hope, the intended impact of all these adaptations.
Well, the clear aim is that participating in these trials will now be significantly less burdensome, easier, more manageable for patients and their families.
Which, logically, should mean
hopefully better recruitment to start with. The trial looks more doable. And, critically, better retention. More people sticking with it to the end.
And better retention means better data.
Exactly. More complete data, higher quality data, which ultimately makes the trial results more robust and reliable.
This study really does make a powerful case, doesn't it, for genuinely listening to the people most affected, the patients, the caregivers.
It absolutely does.
Yeah.
It shows patient-centered design isn't just a nice thing to do. It's strategically smart. It makes the research itself more effective, more feasible.
And ultimately, more likely to succeed in finding answers. Designing trials with people, not just for them.
Precisely.
It does make you think, though, going back to that home spirometry feedback, liked for convenience, but sparked worries about using it right. And the changes they made because of that feedback, it makes you wonder what other things that we think of as standard in clinical trials, maybe across all sorts of diseases, what other procedures or technologies might be creating hidden burdens or anxieties.
Anxieties that we just don't see from the outside, from the clinical perspective.
Things we might only uncover if we did this kind of deep dive, this direct, participant-focused scrutiny, asking people, okay, that standard procedure, what was that really like for you?
That's a fascinating thought, isn't it? It suggests there could be quite a few blind spots in how we design trials, things that seem fine on paper but are actually quite challenging for the people going through them. Really makes you consider what else could benefit from this kind of patient-centered